going. All right. Well, welcome everybody to this week's virtual meetup hosted by the Epilepsy Foundation of Wisconsin. My name is Alicia Thompson. For those that don't know me, I am the program manager here at the foundation. John, since you're on the screen, do you want to just give a quick introduction of yourself?
Sure. Hi, everybody. Good evening. My name is John. I work also for the Epilepsy Foundation of Wisconsin, Alicia's colleague, and I work mainly with client support services and communications.
Great, thank you. So you'll notice we have someone else on the screen. So we have Dr. Janelle Schneider with us. She is an epileptologist with Froedtert Hospital and Medical College of Wisconsin. The topic tonight is going to be basic diagnostic testing for epilepsy. And Janelle will get into her slides in just a few minutes, but I do want to go over some housekeeping stuff. So as I said in the beginning, we are recording this and it will be up on our website. John, if you wouldn't mind typing in the website in the chat, please.
You got
it is epilepsywisconsin.org. So the recording should be up within the next couple of days or by early next week, so you can find it there. And if you're an attendee on the call tonight, just know that you are muted and your videos are off, but you can still ask questions. We do encourage that. Please use the Q&A button, which is at the bottom of your screen. John and myself will be monitoring those questions. And then just for sake of time, just know that not all questions may get answered here on the call tonight, and just try to keep questions general, again, just for the sake of time. We do have an email, though, that you can send questions to that you think of after the call, and John can also type that in the chat section too, which is connect@epilepsywisconsin.org. I believe that is all the housekeeping stuff, so I'm gonna turn it over to Dr. Schneider, and Dr. Schneider, I'm gonna get your slides up while you're saying hello.
All right, hi everyone. I'm Dr. Schneider, welcome, and thanks for joining us tonight. Again, tonight we're going to be talking a little bit about the basic diagnostic workup for epilepsy. And I'm going to go through that. I think I tried to keep my slides to a minimum because I think there may be quite a few questions about this. So again, at the end, feel free to put your questions in the Q&A. Oh, yep.
I just want to make sure, can you see the slides?
Yep, I can. I
All
can't.
right.
Now, am I able to advance or do I have to tell you to?
Yeah, you'll have to tell me.
Okay, you can go to the first one.
All right.
Okay, so what is epilepsy? So this is just kind of our introduction to our discussion tonight. So before we talk about how you make a diagnosis of epilepsy, we have to talk about what is epilepsy. So there is a definition that we use as neurologists. So basically, epilepsy is a neurological condition, and what it means is that the person has an increased tendency to have seizures. And seizures, in their very simplest description, are electrical episodes that occur in the brain. So our brain is full of electrical circuits, and sometimes that electricity fires off when it's not supposed to, and that's what a seizure is. So as neurologists, what we look for to make a diagnosis of epilepsy is the person that we're seeing has to have had more than one, what we call unprovoked seizure. So unprovoked is the key word here, okay, because anybody can have a seizure depending on something else going on in our bodies. So for instance, if we have an electrolyte abnormality, like a low blood sugar, something like that, all of us, any of us could have a seizure. So an unprovoked seizure means a seizure that we don't really have a good explanation for why it occurred. So if a person has more than one of those unprovoked seizures, that meets diagnostic criteria for epilepsy. The other thing that can meet diagnostic criteria is a single unprovoked seizure and then some added risk for recurrent seizure. And I'm going to go into that a little bit more. So I'm going to go into how we decide if somebody has that additional risk. Okay. So in general, it's a common condition. 1 out of 26 people is diagnosed with epilepsy at some point in their life. Okay, go ahead. Okay. So again, like I just said, 2 unprovoked seizures equals epilepsy. That's really all it means. 1 unprovoked seizure, as I said, with increased risk for recurrent seizures. So how do we decide that there's this increased risk that meets kind of those check boxes for a diagnosis of epilepsy? So the neurologist you see is going to look at a number of things to try to figure out if there's some additional risk there. So a lot of it is going to have to do with the story that you tell them. So as they take your history and learn more about you, things that will kind of maybe raise their concern for epilepsy are if you have a history of some of these things here that I list. So a history of stroke, people with a history of learning problems or developmental disorders definitely can have an increased risk for seizures or epilepsy. So things like autism, history of brain injury, so traumatic brain injury or brain injury of another kind, history of brain surgery, dementia, including things like Alzheimer's disease, a history of brain infections, so something like meningitis, brain tumors, or anything else that really disrupts the structure of the brain can be things that your doctor learns about you that make them more concerned that you might be at increased risk for having epilepsy. There may be things on the neurologic examination that your doctor discovers that make them concerned about an underlying neurological disorder that is associated with epilepsy. So that might be something. And then there's some kind of key diagnostic tests that we do, and we'll go into those in more detail, including the EEG and then Neuro Imaging. And then depending on the particular patient, sometimes we use things like lab tests or genetic testing to help us with the diagnosis. Okay, so we're going to start with talking about an EEG because by and large, this is probably the one thing that everybody who's had a seizure, with rare exception, is going to get. So an EEG is simply a recording of brain electricity. I spent some time trying to think to myself today as I was looking through these slides, what are the situations when I don't order an EEG after somebody has had a seizure or what I think might be a seizure. And really, there's not that many circumstances where the EEG isn't ordered. The one thing that I would say is pretty common is a febrile seizure. So that's a very specific circumstance when a toddler has a seizure in relation to fever. So that's a situation where we don't always get an EEG. So why is it important? So again, if you go back to what we talked about, a seizure is an electrical episode in your brain. So the EEG is a way for us to record that brain electricity and kind of see what it looks like. So what we're looking for are abnormal electrical patterns that suggest an increased risk for recurrent seizures. So keep in mind, and this is really, really important, and I try to emphasize this with every patient I'm seeing with a new diagnosis, that most patients with epilepsy, with known epilepsy, if you do an EEG in between seizures, a routine EEG, it's going to be normal. And what I always tell them is that an EEG is like a snapshot. And the analogy that I like to use, I think this is pretty helpful, is, an EEG is like taking my camera out to a street. Think of any busy street. And I take my camera and I snap a picture. And if I look at that picture and at the second that I snap that picture, there happens to be no cars in the middle of the road, that does not mean that it's safe for me to stand in the middle of the road. So in other words, that's a snapshot picture of that road, but it doesn't really tell me about what was happening on that road 5 seconds before my picture or 5 seconds after. So that's an EEG is very similar. It tells us what the brain electricity looks like while we're recording, but it really doesn't tell us what happens before or after or what was going on during the patient's seizure. So why do we do it? Well, we do it because it's helpful if it does show us something abnormal that helps us make a diagnosis. If you've ever had an EEG, very commonly sleep deprivation is something that's recommended the night prior to the EEG. And that's because sleep deprivation can help increase our chances of seeing something abnormal. We also like to see both awake and asleep because the brain electricity looks different in those states. So sleep deprivation sometimes helps ensure that we have a sleepy patient who will take a nap during the test. So routine EEG is usually about an hour long. The patient has to have the electrodes applied. So all in all, the whole procedure takes about 90 minutes. A longer EEG sometimes is recommended to capture a longer sample of EEG. So if you think about what I was saying about it being a snapshot, sometimes it's useful to look for a longer period of time, particularly if a short EEG looks okay and the suspicion is pretty high. Sometimes we do a longer EEG to get a better sample or a longer sample. Okay, and then there's something called continuous video EEG. So this is something occasionally we will do early on in a diagnosis. More often this is done kind of later on, but a continuous EEG is a video EEG is exactly what the name says. So it's the EEG test. It's recorded continuously for a long period of time with a simultaneous video recording. So this is useful if a person is having very frequent episodes where we can actually maybe catch one while the EEG is recording. And then the EEG is not really a snapshot, it actually catches the episodes, and we can look at the brain electricity during the seizure, and that can definitely nail down the diagnosis and give us more information about the person's seizures. This is really difficult to do for most people because for most people, the seizures aren't frequent enough, especially early on where this makes a lot of sense. This type of testing is typically done in specialized epilepsy centers where we have units that are designed specifically for this type of testing. Occasionally, this type of testing is done at home, but that has to be the right type of patient. Okay. So again, what are we looking for? So we really have kind of two categories of what we consider to be abnormalities on an EEG. The first ones are what we call epileptiform abnormalities. So these are the abnormalities that we know are associated with an increased risk for seizures. And then we have a variety of what we call non-specific abnormalities. So these are abnormalities that, yeah, you know, technically that brain wave doesn't look exactly normal, or it doesn't fit the pattern of what should be normal, but it's not the type of abnormality that is associated with an increased risk for seizures. So a lot of times those are just kind of, we notice them, definitely keep it in the back of our mind, but it's not something that necessarily triggers a diagnosis of epilepsy. For me, sometimes seeing those non-specific abnormalities, for instance, on a short EEG, that might be something that triggers me to get a longer look. Okay, and then this is just a picture, kind of what it looks like. So this is the patient, obviously, here on the left. And those little white squares are pieces of like gauze with some paste underneath them that are affixing electrodes, little small round metal electrodes to very specific spots on the scalp. And then you see there's usually a couple of electrodes also recording heart rate, and sometimes other places too, depending on what we're looking for. And then that picture on the right is really just kind of a basic example of what an EEG tracing looks like when we look at it. Okay, and the other big category of diagnostic testing is neuro imaging. So meaning pictures that we take of the brain. So why is neuroimaging important? So neuroimaging we do because we want to make sure that there is not an underlying structural abnormality that is causing that increased risk for seizures. So there are times actually when neuroimaging is not necessary. And a couple of them are, there are some very specific childhood epilepsy syndromes where the history, so what the seizures are like and what the parents tell me and what the EEG looks like are so classic for that particular epilepsy syndrome that I don't feel the need to do a neuroimaging test. So those are some circumstances where I might not do that. Febrile seizures, again, because those are generally not associated with any long-lasting neurological issues. that might be a situation too where neuroimaging isn't recommended. Sometimes with really small kids, I might hold off a little bit if I don't think it's urgent because I don't want them to have anesthesia. So there's reasons where this might not happen. Again, important note, just like the EEG, most people with epilepsy are going to have normal neuroimaging because the seizures are an electrical problem, not a structural problem. So most of the time, the imaging is going to be normal. So there's two kind of most common neuroimaging tests, and those are the CAT scan and the MRI. So we're going to talk a little bit more about those. So a CT scan or a CAT scan. So this test uses radiation, similar to an X-ray, to take a picture of brain structure. So a CT is really going to be best for looking for major structural issues or things like bleeding. And so typically the CT or the CAT scan is something that's done in the emergency department just to make sure that there's nothing urgent going on that's caused a seizure. Sometimes we use contrast dye, which can make the CT a little more sensitive to pick up other things. CT dye is iodine based, and so there are some people that have an allergy to CT dye. It can still be given though with special protocols and pre-medication. And CAT scan is generally pretty quick, maybe 20 to 30 minutes. So an MRI, which stands for magnetic resonance imaging. So this test, instead of radiation, is using a magnetic field, and that magnetic field causes tiny little particles in our brain to kind of move, and then that's how the machine generates images of our brain. So the MRI gets much more detailed images, and there's some very fancy types of MRIs that we can do now these days to get a really kind of detailed picture of the brain and all different parts of the brain. So we also use dye, sometimes IV, to improve the sensitivity. MRI dye is not iodine based. It's something called gadolinium, and the risk of allergy is much less with that. So the MRI takes a little bit longer, depending on what type of MRI is ordered, somewhere around an hour. Again, it's a much more sensitive picture. So the things that we can see on an MRI that we might not see on a CAT scan include things like scarring, blood vessel abnormalities we can see better on an MRI. Areas where the brain tissue may not have developed correctly during early development. Tumors are easier to see on MRI typically, and then areas of inflammation can also be seen more easily on MRI. One thing you'll commonly hear about MRIs is the whole metal issue. So because it's a magnet, certain types of magnetic metal that people might have in the form of implants or really old surgical clips, bullets, those kinds of things can be a contraindication to the MRI. So that's something that we always have to ask about and think about. There are now places where MRIs can be performed even in people that have pacemakers. So that used to be if you had a pacemaker, you just couldn't have an MRI. There are certain places now where that can be done. So this is a picture of a CAT scan. So as you can see, it's kind of like a donut shaped machine and fairly wide open as far as the opening where the patient, where their head goes. So that's what a CAT scan machine looks like. Now, this is an MRI scanner. So you'll see the difference. One of the main ones being, if you look at the picture on the right, the space that the patient goes through or their body goes into during the MRI scanner is a much smaller space. So claustrophobia can be an issue for some people because some people don't like to be in tight spaces. Now, when you get an MRI of, let's say, your knee, you may go in feet first. People typically don't have an issue with that. But when you get an MRI of your brain, you do have to go in head first. And the other thing that people don't like is if you look over on the left side, that's what we call a head coil. So this is a a kind of extra piece on the bed that the patient lays on that helps to secure the head in the right position to get the best pictures of the brain. So some people would maybe do okay with the MRI scanner, but they don't really like that contraption being around their head. So this can be a challenge for some people, but definitely there are things we can do to help people feel a little more relaxed. Medication you might be able to take beforehand or get during the procedure to help you relax if you're somebody who's nervous or claustrophobic. For people that are really, really claustrophobic, sometimes we even have to use anesthesia. For kids that are not able to sit really still for this, then we also use anesthesia. So I just wanted to show you some examples of kind of the pictures and what they look like. So the top pictures are MRI images, the bottom are CAT scan images. And this maybe is not the best example, but hopefully you can appreciate that on the upper images, first of all, we can manipulate the way that we look at the brain a lot more. So we can look at it from different angles that we may not be able to on the CAT scan. And then the CAT scan pictures are just a little bit fuzzier. And so we don't get quite the amount of detail that we get on MRI. And then the MRI has a number of different sequences we can look at where they change different things about how the machine is taking the picture that allow us to see different structures better. Okay, so in summary, epilepsy equals more than one unprovoked seizure or the single unprovoked seizure plus increased risk for recurrence, which for every patient may be different set of things that kind of make your doctor say they think that this is epilepsy. So most of the time, MRI and a routine EEG will be ordered, and most of the time they will be normal. Additional testing can aid in the diagnosis, and that's very much person dependent, patient dependent. And because of the limitations of these tests, sometimes it can take time in order for your doctor to feel really confident about the diagnosis. So that's all I have.
All right, let me close the slides really quick. All right, they're gone on your screen?
Yep.
Wonderful. So now, yeah, we can open it up to some questions. If anybody has any questions for Dr. Schneider, now is the time to please go ahead and use the Q&A button. Hold on one second. All right, I want to make sure my screen is okay. So Dr. Schneider, this may be a silly question, but you mentioned the video EEG, I believe the one that can be done at home. You did say that it has to be a certain type of patient. So I'm just curious, who would that be? Well,
so I'm trying to think of probably the most common situation. So sometimes we do the home EEG out of convenience.
Okay.
Because it's a person that has young children or other life circumstances that don't allow them to come into the hospital for 5 to 7 days for testing. So sometimes it's for convenience purposes. Or if it's someone that's maybe not having seizures quite frequently enough that we might be able to get away with doing a longer one at home. Or some people really will not have their seizure unless they are in their home environment with their usual stressors and things going on around them and their usual activities. So sometimes that plays a role. There are things we can do with the inpatient video EEG that we can't do at home safely. So again, the inpatient video EEG is done in a very controlled setting in units where, we have skilled nurses. And so we can even play around with medications when we do it in the hospital, which is sometimes the benefit, but we just can't do that safely at home.
Okay, makes sense. I think it's really interesting that can be done at home though,
Yeah. There's circumstances where it definitely is really helpful.
Yeah, that's for sure. I have another question too. You talked about, so we saw the MRI, And what was that device called again? Because I think of it as a cage. Obviously, it's not what it is, but that's what it looks like.
Yeah. The head coil.
Yes.
Yeah.
Yeah. So I've never had one before personally, but I just wonder, I know you talked about having to, if it's like children having to get sedated, whatever, medication and stuff. I am not familiar, so this might be another silly question, but is any movement at all allowed? Like, because when I saw that picture, I think they're like in there. So I'm just curious.
So the more still the person is, the better. That's going to give you like the crispest images. So the way the MRI is normally done, so I said an hour, but so there are series of pictures that are taken over the course of that hour. So normally the way it would work is they'll set the machine for the first series of images, and that may be maybe 3 to 5 minutes. Okay. And so then you have to be super, super still for that 3 to 5 minutes. And then usually the technician will come on and say, okay, we're going to get ready for the next set of images. So yeah, you can wiggle around a little bit at that point. The head coil really keeps your head pretty stationary. So there's not a lot of people can still move their heads, unfortunately. And so sometimes it can still mess up the pictures, but.
I gotcha. Okay. So could it be possibly longer than an hour if parts have to keep getting redone?
Yeah. So sometimes they will redo them if they can tell right away that it wasn't a good series. And then one of the other things that can make it a little longer is, like I said, we can manipulate what types of pictures we take. So sometimes we want more images kind of in a certain way. So that might make it take longer. And the contrast is a whole nother series of images if we're doing that. So it depends kind of on what the doctor orders. Mm-hmm. It can take longer than that.
Okay. Interesting. Let's see. Looks like there's a question. Hang on. This one says, do inpatient EEGs have to get taken off the medications for a long-term hospital stay?
Depends on the person. So if I'm bringing someone into the hospital that has seizures a couple times a week, sometimes I don't need to take them off of medicine to catch a seizure. Sometimes I will do that anyway if I'm trying to change medications around. So sometimes the video EEG is a good way to monitor what's happening during a medication change. Mm-hmm. If it's someone that has a seizure once a week, once every couple of weeks, then we bring them in, we take them off of medications and with the purpose of trying to catch a seizure. But again, that's really only something safe to do in an epilepsy monitoring mm-hmm. unit.
Yeah, that makes sense. John, do you see any other questions at this time?
Yes, there's one here. Dr. Schneider, how common is it for someone to get epilepsy because it's in the family history and genealogy?
Yeah, so that is a really good question. So most of the time, there's not a family history. Family history in a first degree relative does increase your risk of developing epilepsy. Okay. But keep in mind that 1 out of 26 people, right? That statistic. So, if you come to me and you're a newly diagnosed epilepsy patient and you say, well, my grandfather and my maternal uncle, again, 1 out of 26 is pretty high number. So sometimes it's not unusual to have a family member with epilepsy. And it's not necessarily genetic or related to your epilepsy. Now, the other thing is that we're learning so much about the genetics of epilepsy right now. It's exploding. And that's because more and more people are getting genetic testing done. So we are finding we're learning a lot more about how the genetics of epilepsy work. And it turns out that, we used to think, and this is the same with lots of other medical conditions that we've known have maybe some genetic component. The same principle is being discovered about them as well. So what we used to think is if you inherited a specific gene from your mom and your mom had epilepsy, and we knew that that gene caused your mom's epilepsy. If you inherited that same gene, then your epilepsy would look the same. But it turns out that the same gene that maybe you inherited from your mom or your dad can cause a very different epilepsy for you, or you may not get epilepsy. And so this, again, like I said, is not just epilepsy specific. It's something that we're learning about genetics in general. The more people are getting genetic testing, is it's not quite as simple as we thought it was. So there's a lot of other things that probably play a role in how that gene expresses itself in a person. So.
Thank you.
Yep.
In your last slide, you had said, in addition to the MRI and this CAT scan, there can be other types of tests that can help a doctor make a diagnosis. What might be some of those examples of other types of tests?
Okay, so I said, we talked about neuro imaging, EEG, and then I think I mentioned genetic testing, which I kind of just touched on. The other thing I would say about that is genetic testing can be helpful specifically in the pediatric population, where maybe a child is presenting with some other medical or neurological issues that make me suspicious about a particular syndrome that I know is associated with epilepsy. And then there can sometimes be other lab tests that might be done that suggest some other underlying condition that is associated with epilepsy, what we call kind of metabolic disorders. And I mentioned also, I think the examination sometimes triggering a diagnosis, and that, again, more commonly in the pediatric group, if we see something on exam with kids, sometimes there can be skin related changes that are associated with specific epilepsy syndromes. So if you saw something like that, that might be a situation where the physical exam helps you with the diagnosis. I'm trying to think if there was anything else specifically that I mentioned. I think those are the big ones.
Okay.
Anything else, John?
Yeah, one more. How closely, if at all, is epilepsy associated with clinical depression?
Okay, well, the statistics are, depending on the study that you look at, that more than 50% of patients have depression or another mood disorder. Okay. And I think the important thing that we're learning is that the depression is not you're depressed because you have epilepsy or you're depressed because you have seizures. It's actually part of the brain disorder. So epilepsy, what I always say to people, epilepsy is not just seizures. Epilepsy is seizures plus the other things that happen in your brain, and mood disorders are one of them. Memory and focusing problems are another. So yeah, it's really not just seizures. So.
All right. John, I don't see any other questions.
I don't either at this time.
All right.
Okay.
So again, you can use the connect email that John typed in the chat section. If you think of something after the fact that you want to ask Dr. Schneider, John or myself can get the question to her, and then she can, we can get the answer back to you. That's no problem at all. But since there's no more questions, Dr. Schneider, thank you so much for your time and your knowledge. We appreciate it. And thank you everybody for being on the call tonight. We will see you next week.
Thanks everyone. Have a good night.
Good night.
You too. Bye.